Medical disclaimer. This video is produced for entertainment purposes only. I am a retired MD and PhD in biochemistry with specialization in orthopedic surgery, spine surgery, chronic pain management, and medical aesthetics. I am not currently practicing medicine, and nothing in this series constitutes medical advice, diagnosis, or treatment. All analysis presented is speculative, based solely on publicly available observations. This is the episode many of you have been waiting for, and the one where I must be most careful, most precise, because behavioral observation without formal neuropsychological testing is inherently limited. What I offer you today is a clinical framework, the kind of structured thinking a psychiatrist or behavioral neurologist would apply when confronted with the observable behavioral patterns of this individual. Not a diagnosis, a differential. The first and most clinically significant behavioral sign is perseveration. In neurology and psychiatry, perseveration has a specific definition. It is the uncontrolled involuntary repetition of a particular response, a word, phrase, theme, or action, despite the absence of an ongoing stimulus that would justify it. This is distinct from rhetorical repetition for emphasis. A skilled politician uses repetition deliberately. Perseveration is different. The brain cannot disengage from the topic. It returns compulsively, regardless of conversational context. Perseveration is a reliable clinical sign of frontal lobe executive dysfunction. The prefrontal cortex, specifically the dorsolateral prefrontal cortex, is responsible for cognitive flexibility. When this region is damaged by ischemia, neurodegeneration, or metabolic insult, perseveration emerges. The second clinical finding is what psychiatrists and neuropsychologists call confabulation. This is profoundly misunderstood by the public, who tend to interpret it as lying. It is not lying, in the deliberate, purposeful sense. Confabulation is a memory phenomenon in which the brain, faced with a gap in memory, spontaneously generates plausible-sounding information to fill the gap, without any intent to deceive, and often without awareness that the generated information is fabricated. The patient behaves like someone who genuinely believes what they are saying. This is seen in Korsakoff's syndrome, in early and mid-stage Alzheimer's disease, in frontal lobe dementia, and in vascular cognitive impairment. The third major psychiatric finding is frontal disinhibition. The frontal lobes in a healthy brain function as the executive brake system. They modulate the emotional, impulsive, and reactive outputs of the amygdala. When frontal control degrades, the amygdala is effectively released from its leash. The result: disproportionate emotional reactions and the inability to modulate hostility. The filter is gone. Traits that may have been present in more modulated form throughout a person's life become amplified, exaggerated, and clinically apparent. This accounts for escalating retribution obsession and grandiosity. These are not political observations. They are clinical ones. Here the psychiatrist must be cautious. There is a recognized history of behavioral characteristics in this individual consistent with narcissistic personality disorder. The critical clinical question is, are they escalating beyond their historical baseline? Is there evidence of quantitative worsening? In neurodegenerative disease, pre-existing personality traits are not replaced. They are disinhibited and amplified. Frontal damage removes the neurological restraints. The answer, based on observable longitudinal evidence, appears to be yes. The patterns have intensified in ways that exceed political or rhetorical explanation. Watch for increasing frequency of publicly observable word-finding failures or mid-sentence topic drift. Growing confusion in unscripted settings, town halls, press gaggles, impromptu remarks. Growing reliance on scripted teleprompter delivery. Any episode of apparent spatial disorientation or failure to recognize familiar individuals. These are the clinical milestones of advancing cognitive impairment. Coming up in Episode 5, the evidence suggesting that specific intravenous medications for dementia treatment may be in use. Learn more about this and other stories at unbedsidemanners.com. Our series concludes with a look at the monitoring requirements for those drugs.